ولا مين؟ انت اللي كتبتيها وانت اللي عملت لها شيرنج يعني؟
هي يا دكتور أنا.
اوكي طيب and get going with the peds. Tomorrow is off and you've already decided that next week will be off. We'll be off next week. On Thursday, inshallah, we'll be reviewing the rest of the peds images. I think we'll get through them. And then after the vacation, we'll get back to whatever is left from the peds, and then we'll get through anesthesia very quickly, inshallah. If today we'll be discussing TOF يعني tracheoesophageal fistula with atresia without atresia, and Meconium illeus, congenital diaphragmatic hernia والميكل. فمين بقى السبوكس بيرسون بتاعنا النهارده عشان يعمل معانا يبتدي بالميكل؟ هل حد هي volunteer؟ السبوكس بيرسون ده بيبقى مهم قوي على فكره. I thank all spokes people because they volunteer and they prepare the stuff and they take the initiative and they don't bother about being asked and answered in front of everyone. They take a lot of يعني ايه مش عارف الكلمه ايه لكن I really thank them all. I thank you all obviously. بس who will be after all that who will be the spokesperson today؟ مفيش spokesperson. يوم الاربعاء هنعمل cleft lip palate. So you can do that under the title of peds or under the title of face and neck, under the title of plastic, whatever. But we're going to do it under peds. ممكن حد بقى يستعد؟
Okay, doctor. I will.
What are you going to do, Pradeep, today? Are you going to be the spokesperson today or on Thursday or on Wednesday?
Today, for today I will be.
Okay. Okay. مرة تانية, I recommend that you all share. I'm always desperate for a spokesperson, but at the same time, I look forward for sharing of all of you. I understand that it may not be comfortable for all of you to share, but it's a great experience as far as I think. Yalla, Pradeep, tell us what do you know about Meckel? What do you know about the Meckel's diverticulum?
It's a remnant of
عين طاف وبعدين Meconium illeus CDH, congenital diaphragmatic hernia. So we're going inshallah through 4 topics today. Okay, go on.
Okay, Meckel's diverticulum. It's a remnant of vitelo-intestinal duct, which usually connect the GIT to the outer opening through the umbilicus. And
start telling us where is it, Pradeep, first of all? Where is it? I mean, tell us where is it, and then discuss its embryology. But where is it? Where does the Meckel lie?
It lies in our small GIT, especially in the ilium part.
Especially, what do you mean in our small GIT? Or small bowel, you mean? But small GIT. Bowel. Yeah. And where does it lie in particular? Where is its location? Where is its standard location?
Its location is in ilium, which is nearly 2 to 3 feet from the cecum.
Okay. And how do you apply this piece of information? How do you apply? You know that this diverticulum lies something like 2 to 3 feet. 2 to 3 feet. How many meters are 2 to 3 feet? How many meters are?
Nearly 2 meter. 3. I think 3, 8 or 9. I guess 8 or 9 meters.
9 meters? Do you really think so? 2 to 3 feet. How much is a foot?
1 feet. It's 1 feet. I think 2.5 or 3 meter.
3 meters. Well, it's only 1/3 of a meter. It's only 1/3 of a meter, and I mean 9 meters is for the small bowel. 9 meters. I mean that's too long. It's only between 60 and 90 centimeters from the ileocecal valve. Okay, it's 2 to 3 feet from the ileocecal valve. Okay, how does this? How do you apply this piece of information? How do you apply this piece of info?
Clinically, I mean, we can palpate right iliac in a right iliac fossa, and first we can search for cecum, and then we can proceed.
Clinically, do you really mean clinically, or do you mean operatively? Clinically or operatively?
Operatively.
Operatively, not clinically, operatively. But clinically, you cannot palpate the diverticulum of the Meckel's type, nor of any other type. Unless it's complicated, it's causing an abscess like the appendix. But while you're operating, if you need to exclude a Meckel, what do you do? If you want to exclude the presence of a Meckel while you're operating, what do you do? You just apply this piece of info. What do you do? Where do you look for it?
I will just measure that length and see whether if there is any protruding part or not in the ileum.
You pull on something like a meter of the terminal ileum, and if it's free of the diverticulum, then there's no Meckel. It applies as you don't need to screen the whole bowel for looking for a Meckel. And the Meckel is known to be only 2 to 3 feet from the ileocecal valve. Okay, go on. How does it look? This is its location. How does it look? How does the Meckel look?
It look like outpouching from the ileal wall, and similar to.
Hold on for a minute. The bowel has got 2 borders, a mesenteric and an antimesenteric border. A mesenteric and an antimesenteric. Which border does it bulge from?
It's a bulge from antimesenteric border.
Okay, so this is how you describe it. Yes. It bulges from the antimesenteric border. And what about its wall? Is its wall thin or thick?
It's a thin wall, not thick, I guess.
It's thin. Well, okay, this is not a very accurate question. What do you mean by thin or thick? What did I mean by thin or thick? What was the essence behind? What was the essence behind that?
Whether it is containing all 4 layers of, I mean, its wall or not.
Does it contain all 4 layers, or does it not contain all 4 layers?
It contains 4 layers.
Okay, so I mean, it's not thin. I mean, my question was not accurate enough, because what is thin, what is thick? But I just meant that you mentioned that the wall is 4 layered. That is, how do you call it? Diverticulum that is formed of 4 layers.
It's true diverticulum.
It's a true diverticulum. Okay. What's a pseudo-diverticulum? What is a pseudo-diverticulum?
Pseudo, just one or two, not all, but few layers just bulges out, but the main lumen remain inside.
Yeah, but which layers bulge? Which layers bulge? I mean, you have to identify the layers. Which layers bulge?
Just mucosa.
Mucosa only, or mucosa and what other layer? Mucosa and
submucosa.
Yes, the mucosa and submucosa. So you can't just say some layers, because what do you mean by some layers? So it's the mucosa and submucosa bulge in between they bulge in between the what?
In between the muscles.
In between the defects in the muscle, absolutely. So a Meckel is a true diverticulum. And what etiology is it? Is it acquired or congenital? Just like you've been trying to describe?
It may be congenital. It's congenital.
It's congenital. You're talking about, I don't know its connection to, I don't know what you'll be mentioning it in a minute. So it's a congenital true diverticulum, as opposed to versus congenital true versus reverse the 2 items. They reverse the 2 items. Congenital true versus
true.
Say congenital and true. What are the opposite? What is the opposite of congenital and true?
I mean, adult plus false type.
What's the opposite of congenital? What's the
It's
opposite of congenital?
acquired.
يبقى acquired false. يعني this is a congenital true as opposed to an acquired false. Where do acquired false diverticular develop? Where do acquired false diverticular develop?
Usually in the large colon, descending colon,
where in the large bowel? Where particularly? Where
in descending colon and sigmoid.
It's a sigmoid. It's a sigmoid. Okay, it's a sigmoid. The pseudo-diverticula of the colon, which are obviously far common in the Meckel, and they're acquired, they develop in the sigmoid. But now we're talking about something, okay, Zenker's pharynx, yes, but as regards the gastrointestinal tract, excluding the pharynx, because the pharynx does not belong to the GI, strictly speaking, you're talking about congenital true diverticulum of the terminal ileum 2 to 3 feet from the ileocecal region, ileocecal valve, I mean. Pradeep, what about this background noise? Can we control this background noise? What about 2 to 3? What about, are we sharing the handout, by the way? Are we sharing it or are we not sharing it?
Not it.
Hazim, do you want me to send you the handout if you haven't got it?
انا هجيبها من الجروب يا فندم. حاضر وهشير حالا. حاضر معلش انا اسف.
حاضر. لا اسف، ما فيش في الموضوع اسف، احنا كلنا ما فيش، يعني ما فيش في الموضوع اسف خالص. Go on. What is the rule of 2 to 3? What is the rule of 2 to 3? There is the rule of 2 to 3 concerning the Meckel. One of them is 2 to 3 feet from the cecum. What else? How long is the Meckel?
And it's 2 to 3%, I think, affect the people.
Okay, 2 to 3% of people. Yes, that is another 2 to 3. Yes. What else?
And it's 2 to 3 inches from 2 to 3 inches long, مثلا.
It's 3 inches long. Yes, yes, it's 2 to 3 inches long. Well, how long is an inch? How long is an inch?
It's nearly 2.5 centimeters.
It is 2.5 centimeters. And how much is a foot? A foot is 30 centimeters approximately. So this is only something between 5 and 7 centimeters, something of the sort. Okay.
Yes.
And what is the last 2 to 3? There is the last 2 to 3.
It's 2 to 3. I think it's incident, I guess. 2 to 3. 2 to 3.
You've already mentioned that. You've already mentioned that this diverticulum occurs in 2 to 3% of the population.
2 to 3 feet from the cecum, 2 to 3 inches long, 2 to 3% of incidence, and one last, there is 4 2 to 3. One last, I don't know.
The last one is like Zain was telling us that out of people who have got a Meckel, only 2 to 3 present or only 2 to 3 complicate. Yani, in the whole population, I don't know how many billions, 7 billion human beings, 2% of them have got a Meckel, but out of these 2%, only 2%, another 2%, only a very minor number, only a very few people will complicate. And when does it usually complicate? When does it usually complicate?
Usually, in let know after.
What age group? I mean, what age group? As regards age,
In infant, sorry, 2 to 3 years. Infant any month. Infant is.
Is it infantile? Is it usually infantile?
It's usually infantile, I think.
I think it's usually older. I think it's usually a bit older in children or older than infants. It's usually in childhood. What application does this have? Yani, always ask yourself, what does this piece of information, how does it apply? How does this apply? That it presents usually in childhood. It doesn't present in adults.
Means it will be one of the differential diagnosis if the age group if
بالظبط كده. يبقى you wouldn't include it as a DD in an adult, you would include it as a DD in a child. A DD of what? A DD of what?
It's a DD of abdominal ventral wall swelling or
Swelling? Not swelling? How come? It doesn't present with the swelling. What does it present with? What does a Meckel present with?
Meckel's it's pain, abdominal pain.
Abdominal pain. What type of pain? Acute pain, chronic pain?
Acute.
Acute pain. So it simulates. Where does it lie? Where does it lie broadly? You're talking about
broadly in the right iliac fossa.
Yeah, in the right iliac fossa. And if someone presents with pain in the right iliac fossa, what will your basic diagnosis be? أو ده الميكل أو ده حازم هو الميكل أنت جبته أهو الميكل. Yes, this is the Meckel. What would your basic diagnosis be if someone presents with pain in the right iliac fossa?
Usually appendicitis, appendix pain.
Yes, acute appendicitis usually, but obviously there are so many confounding causes, but it's usually acute appendicitis. يبقى Meckel's diverticulitis will not enter into the DD of acute right iliac fossa RIF pain, right iliac fossa pain, unless in a child. In an adult, it's unlikely. And how about if you encounter a Meckel? Is a Meckel rare or common? Is a Meckel diverticulitis rare or common in the first place?
It's in first place it's rare.
In general, it's rare because we've been talking about 2 to 3% of the population. We're talking about 2 to 3 out of these 2 to 3. It's rare.
Yes.
How about if you encounter a Meckel during an operation? How about if you're operating for any other reason and you encounter a Meckel? Will you remove it or will you not remove it?
We will remove it because we don't need to open it again and again.
In any age? Yeah, the question is in any age? In
adult, I think it's better to operate. In babies, I think we will wait for symptom.
لا أنا دلوقتي I'm talking about encountering a Meckel by chance while you're operating for another cause. You're operating for another cause. You're operating for any other cause. You perform the laparotomy and you encounter a Meckel. Are you going to remove it, just like you were saying, just in case people develop a diverticulitis later on and then you have to operate? Or you just leave it in place? What would you do?
I think it's better to remove.
But it all depends upon the age again, because if they're already older, maybe above 40, 40 is already quite an age, they usually will not present any longer. But if they're younger, in their 20s, طبعا احنا بنقول childhood, but the younger they are, the more pro you're removing it. The older you are, the people are, you don't remove it because it no longer presents. It presents in young people. Okay, what are its presentations? How does Meckel present?
First abdominal pain.
Pain in the right iliac fossa stimulating. It simulates very much and cannot be differentiated from what? زي ما لسه قايلين.
Appendicitis pain.
Appendicitis.
And also if female has.
I'm sorry about that, but because they're both diverticular, it's the same thing. Okay. What else other than pain?
GI bleeding.
How? How do they diverticular bleed?
Bleeding it through the rectum and through the anus, and maybe vomiting also because it's in a small intestine, so it may also.
I mean, this is not the mechanism. This is the presentation. You're talking about upper GIT bleeding and lower GIT bleeding. But I was talking about the mechanism. Why do the articular of the Meckel slide bleed? But let's wait for a minute and let's talk about what you're talking about. Well, if a Meckel bleeds, does it cause an upper GIT bleed or a lower GIT bleed?
It's upper GI bleed.
An upper GIT bleed, really? The upper GI stops at the DJ flexure. So the end of the upper GI is the DJ flexure. If anything, it bleeds distal to the DJ, the duodenal flexure is the lower GIT bleed. It's very unlikely, if at all possible, that Meckel will cause hematemesis. It doesn't cause, it causes lower GIT bleeding.
Melena, yes.
Melena or fresh bleeding. It's either this or that.
Yes.
We're discussing GIT bleeding is a major topic, and we're discussing this in full detail later on. But in general, the definition of the upper GI is up to the DJ flexure, all the way out down to the DJ flexure. DJ, that is the duodenal flexure. And if you're aware that the ligament at this point, how do you call the ligament at the DJ flexure? The ligament.
Ligament of Treitz.
The ligament of Treitz, there's the ligament of Treitz that lies, that is the landmark between the duodenum and the jejunum. And this is the point where the upper GIT stops. And sometimes the middle GIT starts, or better, the lower GIT starts. At times they talk about the middle GIT, but this is not standard. So it's this point that differentiates between the lower GI and the upper GI. So it may bleed, but what is the mechanism of bleeding? Why do diverticula? Or diverticula or diverticuli? What is the plural of diverticulum?
Diverticula.
Or does that divertically exist? Does the word divertically exist?
Divertically, it's similar. Yes, for singular it exists.
It's diverticulum and diverticula, but divertically is the plural of the plural. You haven't got divertically, you just got a diverticulum and a diverticula. Okay. But an AE would be a plural of an A, but this is not an A in the first place. Diverticulum and diverticula. How does it bleed? How does it bleed? Why does it bleed? I don't know.
Bleeding may be due to the infection, superimposed infection.
In fact, not. In fact, not. In fact, زي ما كان زين بيقول, Zain was just pointing to this. A lot of times the Meckel is lined by what is it lying? What about its lining? You've been talking about its wall and its location, and how about its lining? What mucosa lies within it? What type of mucosa lies within it?
It's gastric mucosa, as
it's
Abdul
gastric mucosa, ectopic gastric mucosa. And at which level does this lie? Which level does this ectopic gastric mucosa lie? Does it lie at its tip, at its body, at its base?
I think it's will be the base portion.
It's the base. It's the base. There's the base there, and the two exclamation marks. It's actually the base. It's actually the base. بالظبط كده. It's the base, and the fact that this is the base, when you operate upon the Meckel, you have to remove its base. You cannot remove the Meckel and invaginate its base, because it's the base that is the problem. Okay?
Okay.
The base is the problem. And removing a Meckel is different from removing an appendix. When you remove the appendix, you just remove it and you leave the base and invaginate it. But بالظبط زي ما زين بيقول, but when you remove a Meckel, you need to remove the base, just that is removing a Y-shaped part of, or I mean a V-shaped part of the bowel. Okay? It's bleeding because of ectopic mucosa. Bleeding doesn't usually arise from an itis. Okay, in this situation, bleeding does not arise as a complication of an itis. It does not. It arises as a complication of the presence of ectopic gastric mucosa. And they're present at the base. They're present at the base, okay? So this is... sorry?
I mean, ectopic gastric mucosa, it's present there. Then what actually underlying pathology that causes that mucosa?
It ulcerates. It ulcerates because of the acid. It ulcerates. It simply ulcerates.
Oh, okay.
Just like a gastric ulcer ulcerates, the mucosa, just like a gastric ulcer bleeds, this ectopic gastric mucosa ulcerates and then it bleeds.
There is no counter mechanism to stop that, neutralize that acid secretions. Like in stomach, we have mucosal lining, physical barrier, and also the chemical.
But even the stomach, all these mechanisms do not stop ulcers developing and bleeding. If you compare by the stomach that is equipped with mechanisms to counteract the acidity, and the small bowel mechanisms are much less.
Yes.
Okay, I can go on. Did you want to say something?
No. That is what I was asking. In stomach there is a counter mechanism. In normal physiology there is counter mechanism to neutralize the acid or to protect the mucosa, but in diverticulum there is not such thing, I guess.
Okay, but what I was adding is that even the stomach that is equipped, like you were saying, with mechanisms to counteract the acidity, the gastric mucosa at times breaks and it bleeds. Even the stomach that is best equipped with mechanisms to counteract the acidity, but in the small bowel, this is much less. Obviously, there's a good chance that it bleeds if it's lined by ectopic. At times, it's said that it's lined even by pancreatic mucosa, but who cares? It's not of great importance, practically speaking. Meckel, remember that the bleeding is not a result of an itis. The bleeding this is just an analogy, neither in sigmoid diverticulitis. In sigmoid diverticulitis, the bleeding does not develop. Bleeding develops in sigmoid diverticulum separately from an itis. It's not about an itis. It's about an ectopic gastric mucosa.
Okay.
What other complications can develop?
Complications that can bleeding.
You can just go through what's written, and you can sort of integrate it and mention it if you want. If you don't want, it's entirely up to you. And I want someone with a cleft lip and the palate who will actually prepare this. We insist on what we're going to discuss the next day in order for it to be prepared. It would make a great difference, by the way. If you already read something and then you hear it, if you've heard something and then you read it, if you do both, it will be great. How about a hernia that contains a Meckel? How do you call it?
It's a circumference. It's called Litter's hernia.
Litter's hernia.
Yes.
Litter's hernia. And what is its problem? What is the problem with the Litter's hernia?
It's the problem is it's a sliding. It come and goes, not exactly sliding, but it's a circumference. If we incise
is it a sliding hernia? Is a Litter's hernia a sliding hernia?
It's not a sliding. Sliding is in
not a sliding hernia. The diverticulum lies within the sac, not outside the sac. But what happens if someone has got a Litter's hernia and they become strangulated? The hernia becomes strangulated.
That can lead to perforation.
You can perforate, but they won't be obstructed.
Yes,
you touched on that because you're talking about the partial anterior seed. You're talking about it. It's like a Richter.
Yes.
Remember a Richter's hernia. But the importance of a Litter's hernia, which is very, very rare, obviously, because Meckel's diverticula are not very common. 2 to 3% means that there is quite a number of people with a Meckel, but they're only 2% of the whole population. In order for someone to have a hernia with a Meckel inside it, it's unusual. But if they've got this situation, then they'll develop internal obstruction without strangulation, without obstruction.
Without obstruction.
Okay. How can a Meckel cause intestinal obstruction?
دكتور كده الليتري هيرنيا دي بتيجي برضه في التشايلد هود ولا ممكن تيجي في الكبار؟
هتيجي في اي حد. This is not limited to children because it's a diverticulum, and then in this situation the diverticulum is not complicated. It's the hernia that is complicated. Okay.
مش فاهمة.
يعني also what is the essence of your question type? Why are you asking this question? What is behind the question?
بس احنا قلنا ان الميكلز بيبريزنت في التشايلد هود بس مش بنحطه في الديفرنشال دايجنوزس بتاع الكبار.
Okay, this Meckel did not complicate. This Meckel was present in the hernia by chance. It did not complicate. It was part of the bowel, just like part of the bowel is present in hernial sac. So it's not a real complication of the Meckel. It's a complication of the hernia that happens to include the Meckel. يعني واخده بالك من الفرق زي someone has got their bowel inside the hernial sac, and then the hernial sac becomes strangulated and the bowel suffers. If it happens to include a Meckel, the Meckel will suffer like any other part of the bowel, but it does not mean that the Meckel has become complicated. It's the hernia that has become complicated. By chance it's completely containing a Meckel.
اوكي يعني هو ما بيعملش هو نفس complication غير في الصغيرين، بس الهرنيا تيجي في الصغيرين وفي الكبار، صح؟
ايوه بالظبط، تيجي في الصغيرين في الكبار فيها ميكل بالصدفه، يعني فيبقى it's just there by chance just like the appendix. مش انت عارفه ان ساعات الهرنيا بيبقى فيها appendix برضه، وانت اللي قلتيها متهيألي مره، اسمها ايه لما الهرنيا بيبقى فيها appendix؟
اميانز هرنيا تقريبا.
صح. يبقى يلا براديب جو اون. نور عاوز تقولي حاجه ثانيه ولا ايه؟
لا ثانك يو يا دكتور.
اوكي دلوقتي I just want to remind you of something. we're using PEDS a lot in order to emphasize a few principles in GIT surgery. Well, remember that three complications that are very common to all GIT diseases are a bleed and the perf and an obstruction. The three complications that are very common and three presentations that are very common to almost all GIT diseases are a perf, a perforation, obviously that starts with an inflammation probably, and a bleed and an obstruction. If you talk about a peptic ulcer, if you talk about ulcerative colitis, if you talk about carcinoma somewhere, remember that three very common complications of almost all GIT diseases, very common complications are a perf, a bleed, and an obstruction. The answer, the question is now, how will a Meckel cause? يعني it can cause a bleed, it can cause a perforation because it can cause an itis. An itis is the predecessor or the forerunner of a perforation. Usually, if things become inflamed, they can obviously become perforated. But طبعا at times things perforate without an itis. Like set this aside at the moment. How can a Meckel cause an obstruction? هم موجودين.
Yes, in long run there will be impaction of food, meconium, and that can obstruct. Or
food and meconium. Why are you دلوقتي food and meconium? And on the long run, why are you connecting food and meconium?
It's meconium, not.
We're talking about a child. We're not talking about an infant or a neonate. We're talking about a child. The meconium is gone. We're not talking about an infant or a neonate anymore. We're talking about a child. A Meckel is a childhood disease. A Meckel is not an infantile, neither a neonatal disease. It's a disease of childhood. It's past infancy, and it's definitely not a neonatal problem. But we haven't got a meconium anymore. And we're not talking about obstruction of the base of the Meckel. We're not talking about that. We're talking about obstruction of the bowel. When the base of the Meckel becomes obstructed, it causes an itis, but it does not cause intestinal obstruction. We're talking about actually intestinal obstruction. The forerunner of an inflammation anywhere is an obstruction. It's a stasis. But remember that stasis is a forerunner of an itis, just like when people start lingering and not getting along, and then the police are watching them, and then police are very much worried about why are they lingering and why not they not get going. They're planning for something or what? It's the same thing. When there is stasis in something, this is the forerunner of an itis, just like the appendix, just like the gallbladder, just like a diverticulum in the Meckel's type or the sigmoid type. There is stasis because its neck becomes obstructed and then becomes inflamed. But we're talking about an internal obstruction.
Okay.
Tell me something about the embryology of the Meckel. Tell me something about embryology of the Meckel.
Okay. Usually during embryology, our intestine intestine during the development, it's rotate 270 degree, and that axis,
About the rotation, we should be talking about only the junction between it. If we talk about the rotation, it will become more complicated. But just let's talk about the duct that connects the bowel to whatever.
It's a vitilo-intestinal duct that connect ileum to the.
No, if we talk about it, let's just to the duct that connects the ileum to what? How is it called?
And that connect to the yolk sac. Hello?
Yeah, I'm around. I just got a phone call and that's over. خلاص. يلا, tell us something about the duct that connects the ileum to the umbilicus. How do you call it?
Ileum to the umbilicus. It's a fistula. Sorry, I mean, if there is opening, then we will call it fistula.
Yeah, but how do you call this duct embryologically speaking? Embryology wise, how do you call it? It's written there. You can. I mean, umbilicus. Sorry, have you not got the handout?
No. I can see that it's vitilo-intestinal duct.
بالضبط. What other name is there for the umbilicus? Have you got another name for the umbilicus?
Yes, omphalomesenteric.
It's the omphalomesenteric duct. It's the omphalomesenteric duct that connects the part of the ileum. So the ileum is considered as foregut, midgut, or hindgut. What is it? Ileum? Is it midgut, foregut, or hindgut?
It's midgut.
It's midgut. It connects the midgut to the umbilicus. Well, this is the normal. And what are the possibilities? This duct should become obliterated. Well, what are the possible findings if it doesn't become obliterated? You can see them all there. Yalla, what happens?
In case it's don't get obliterated, then there will be two opening, one outside and one inside the lumen of the intestine, and that we call the fistula. And
there's fistula at which level? At which level on the abdominal wall? Which level of the abdominal wall is there this fistula?
It's below and right side, usually a bit right side of umbilicus.
It's a level of the umbilicus. It connects this to the umbilicus. It's the umbilicus. Okay. How about number two? What about number two? What's happening? Number two?
In some cases, both side of the lumen duct get obliterated, and the middle part remain patent, and that will form a cyst.
It will form a cyst. If the entire duct remains patent, it's a fistula. If the middle part remains patent and becomes occluded on both sides, it's a cyst. Yes, and then there remains whether the proximal or the distal parts become patent, remain patent, and the rest becomes obliterated. Yalla, what happens with 3? What is happening with 3?
And in 3, the proximal to the ileum that get obliterated, and distal remain a bit patent.
The part that is connected to the umbilicus remains patent. The rest becomes obliterated. Yes, and then it bulges and it forms a polyp.
Yes.
It bulges and it becomes evaginated and it forms a polyp. Yes, and then how about number 4? What's number 4?
It's the distal portion of the duct to get obliterated, and
the distal is a bit confusing. Let's not talk about distal and proximal. Let's talk about the part that is joined to the bowel or the part that is joined to the umbilicus. Which part in number 4 remains patent?
Umbilical part that get obliterated, but the intestinal ileal part remain patent.
And this is our. What is this then called?
This diverticulum.
Yes, this is the Meckel. This is the embryology of a Meckel. The diverticulum duct that was supposed to become obliterated remains patent at its ileal attachment, while the rest becomes obliterated. But this is simply, and it's the diverticulum duct or the omphalomesenteric duct. And what is number 5? What is number 5?
In number 5, umbilical plus intestinal portion of the duct totally get obliterated, and which
the
simply
whole duct becomes obliterated. Simply, the whole duct becomes obliterated. Yes, but it's replaced by
a band, fibrous band.
A band, and whenever there's a band, What follows if there's a band inside the abdomen? What follows with 4 and 5? There's a band. What follows if there's a band?
The twisting, that mid twist.
It can twist. Yes, a band predisposes to a twist. على طول كده. A band predisposes to a twist or a twist or a band or an adhesion. What can it cause?
Adhesion. It can lead to twisting, obstruction.
Obstruction. It can simply obstruct a loop without it twisting. Okay,
Yes.
these are the mechanisms of some obstruction, and not obstruction of the lumen of the diverticulum. We're not talking about obstruction of the lumen of the diverticulum. The lumen of the diverticulum, it becomes obstructed, it causes an itis. But we're talking about obstruction of the lumen of the bowel, actually, which is some obstruction. That is a volvulus and the presence of a band. The band that causes adhesions, or a volvulus because of the band again. Okay? Remember that whenever you've got adhesions inside the abdomen or a single band more and more sort of predisposes to a twist, like we've been talking about when you're holding a rope at both ends, and obviously you twist it, it twists, but if you're holding it to both end and the other is not held, it does not twist as good. اهو ولكن ناقص كمان Zain was just telling us that because the base of the diverticulum also bulges inside the lumen. The base of the diverticulum bulges inside the lumen. What happens if something bulges inside the lumen of the bowel?
That bulging that can lead to obstruction if lumen.
Well, I mean, it can lead to obstruction if it's a major bulge, but how? And it's a firm one. But this is a minor bulge. What happens if something is minor? Is it got a minor bulge inside the lumen of the bowel?
That is, I mean, that we call a polyp, and that may ulcerate in a long.
Okay, it may ulcerate. Okay, we mentioned that already. But something else, when something bulges inside the lumen, whenever something bulges inside the lumen, okay?
It can lead to intussusception.
بالظبط كده. مين اللي بيقول دلوقتي؟
أنا حازم.
حازم. بالظبط حازم بيقول intussusception. يبقى whenever something bulges inside the bowel lumen, it can lead as a lead point. It can become a lead point or the apex of an intussusception. Okay. That is why in infants, what is the lead point of intussusception in infants who are changing their diet and their food and they're becoming weaned and so on? What is the lead point?
Usually in ileocecal junction, usually the hyperplasia of lymphoid follicles that can.
بالظبط كده. It's the how do you call the lymphoid follicles at this point? How do you call the lymphoid follicles at this point?
Pierce patches.
The Pierce patches bulge, and if they bulge, they don't obstruct the lumen, but they predispose to an intussusception. بالظبط. فيبقى اهو يبقى this is all about Meckel's diverticulum. Pradeep has taken us through the Meckel. حد هيسأل سؤال؟ كان حد عنده أسئلة؟
عندي سؤال.
انت نور؟ قول يا نور.
دكتور، هو المفروض ما يبقاش اي حاجه، صح؟ يعني نمبر 5 ده كده مش النورمال، ان هو فكره حتى ان هو كله اوبليتريتد ده كده ابنورمال. النورمال المفروض ما يبقاش فيه حاجه خالص ولا ايه؟
بيبقى في الباند موجوده. تبقى الباند موجوده.
اوكي، يعني 5 نورمال، باند دي نورمال، صح؟ يعني كل البوبيليشن عندهم ريسك الفولفولس ده.
But it's not a real one. It's not a real one. Okay, but it's there. The band is there. Yes, the band is there.
Okay, thank you.
لا خالص. فيبقى Meckel's diverticulum, like Pradeep has taken us through this disease. It's the most common diverticulum, congenital diverticulum of the bowel, where it's most common anomaly of the GI. In fact, the vitelline sinus duct, like Pradeep was telling us, and it's the omphallo mesenteric duct. These are synonyms. And how the diagram in the middle from which these arrows diverge, this is embryology, and then it can remain patent. The whole duct can remain patent. Well, this is the possible complications when any duct is present during embryology and it becomes obliterated. These are the possibilities. Either the entire duct remains patent. حد عاوز يسأل حاجة؟
Yes, doctor. In case of polyp, that can also may ulcerate or may changes to squamous carcinoma. Is it possible?
It's not a polyp. It's not a polyp. It's just the bulge of the apex of the base. I mean, it's not a polyp. It does not form a polyp. It's just a bulge. It's just a minor bulge.
Okay.
Okay, but it's not. It does not create a polyp as such. It's just a polyp. What do you mean a polyp? A polyp at the umbilicus. A polyp at the umbilicus is not precancerous. It's just a polyp with a raw area that discharges a bit of mucus. But a polyp inside the bowel, it does not develop. It's just a bulge of the base. Zain was telling us, was referring to something else, that is the urachus, the duct that connects the bladder to the apex of the bladder to the umbilicus. It's the same thing. The urachus, if you remember, it causes diverticulum cyst or it remains patent as this connects the bladder to the umbilicus.
Later it changes to medial, I think, umbilical ligament.
Yes, it becomes the medial umbilical ligament. Absolutely, you're absolutely correct. These are the possible anomalies. The whole thing remains patent. The middle part remains patent, forming a cyst. The whole thing remains patent. It's a fistula. The part that is connected to the umbilicus remains patent, while the rest becomes obliterated, and that becomes evaginated and forms an umbilical polyp. Remember that a lot of people will complain of umbilical discharge, but this is the least common cause. Umbilical discharge is usually a bit of fungal infection, sometimes paranoidal sinus, rarely, sometimes this polyp, sometimes cotton fluff. If you're wearing something that contains cotton, a bit of cotton gets inside your umbilicus and you tend to discharge it. Not from inside the body as discharge from the outside. Number 4, out of number 4, it's this is our classic diverticulum, obviously, and number 5 is the band. And all are the possible things. It's present in 2 to 3% of the population. It complicates only 2 to 3% of these 2 to 3% of the population. It's 2 to 3 feet from the cecum. It's 2 to 3 inches long, and I hope you all know the applications. Whenever you're talking about any piece of information, just check how does this apply clinically. How does it apply to the symptoms, to the signs, to investigation, to the treatment. It's a true diverticulum. It's anti-mesenteric border. It's got a separate artery. There is the fibrous band. There is ectopic mucosa. الكلام ده كله قلناه. It usually presents in childhood. It's the base. The base is the problem. The base is the problem. لسه حكايه الميكلز diverticulum scan دي. One that presents elytrace hernia is a hernia that contains Meckel's diverticulum. So what? It's just it's important because if it strangulates, obviously the rest of the bowel wall will still propagate bowel, peristaltic waves, so they do not become obstructed. The band causes an intestinal obstruction. It can also cause a volvulus. The bulging base can intercept. That is why you have to remove the base. عاوز حد يجيب لنا صورة removal of Meckel as opposed to the appendix. It's important to appreciate the difference. When you remove the appendix, the stump, you don't remove, just invaginate it. But when you remove the Meckel, you need to remove the base. Otherwise, you haven't done a lot. It's the base that is the problem. Okay, فعاوزين نجيب صورة، لو في صورة بتاعت removing, excising a Meckel, acute diverticulitis, GLT bleeding because of the ectopic mucosa. Remember that an itis is not related to the bleeding. It's an obstruction by different methods. Remember that if you encounter Meckel's by chance while operating upon any other pathology in adult, usually you do not remove it, because if it's past the age of childhood, then it will not complicate. خلاص ما عندناش حاجه ثانيه خالص نقولها على الموضوع ده غير مين عارف حكايه الميكلز. Pradeep, are you aware of the diverticulum scan? Are you aware of what we call a diverticulum scan?
I think it's like giving barium, and then taking X-ray.
A scan. Probably, we don't usually call X-rays a scan. Okay. X-rays are usually the only imaging modality that ultrasound scans, CT scans, CT scans, لكن usually you don't call an X-ray a scan. I don't know why يعني. لكن
Okay.
in fact اهو الشرير اللي اسمه زين بيقول زين saying is that because it contains ectopic gastric mucosa, it's well known that ectopic gastric mucosa will take technetium. It's a fact that technetium, TC like Zane was telling us, TC99M is taken not only by the thyroid.
And doctor, doesn't we can give barium?
Salivary glands, it's also taken by gastric mucosa. If there is gastric reticulum.
Hello. Hello, Hazim. Can you hear me?
I'm around, yeah, Pradeep. I'm sorry about that. I'm around. But we're talking about the fact that if a child has got bleeding per rectum, usually fresh bleeding per rectum, and maybe melena at times, and we want to exclude the presence of a Meckel's diverticulum, then you get what you call a diverticulum scan. You give them technetium parenterally and IV, I mean, and then you get a scan. You image their abdomen using a gamma camera, and you find the hot spot in the region of the right iliac fossa. Then they've got a Meckel's diverticulum containing ectopic gastric mucosa. Okay. Remember what we call a Meckel's diverticulum scan. The word scan is a very inaccurate word, but it's most commonly applied to a CT scan. If you don't specify it, because you don't, when you're getting ultrasound scan, you don't usually say get a scan of the abdomen. If you're getting ultrasound, you say you get ultrasound. But a scan is usually, but this is very inaccurate, usually first to a CT scan. But obviously, we talk about the CT scan, we talk about the ultrasound scan. So I hope that this topic.
Doctor, in case of sigmoid diverticulosis, in that case, enema is used, right? And the X-ray is done in the initial phase.
But this is very different. Yes, it's very different.
That's why I assumed that, I guess.
The location, it's basically the location. If you give a barium enema, it fills the sigmoid very quickly, but you cannot ensure that a barium enema will fill the terminal ileum. You can't ensure that. At times it happens, but you cannot ensure it. You can't guarantee that, and you can't guarantee that it will fill the diverticulum. But this is not conclusive at all. Like with sigmoid diverticulum, absolutely. You want to diagnose sigmoid diverticulum, you obviously use a barium enema. Yes, this is unless it's complicated. If it's inflamed, you don't get a barium enema. But if it's not complicated, you get a barium enema, and you can find diverticular as a coincidental finding during the investigation of anything else using the barium. Well, remember that barium enemas nowadays are not popular at all. You don't get barium enemas unless in very selected situations. Okay.
دكتور
قولي يا
احنا
نور.
بنستخدم السكان ده بس لو هي فيها gastric mucosa. لو ما فيهاش gastric mucosa مش هيبان بالسكان، صح؟
مش هتبان.
فكده ما ينفعش نعمل لها سكان.
ما هو it's based on the fact that it contains technetium. It takes technetium because of the gastric mucosa. Okay, if it will not show, وهي بتستعمل في situation not when people have got right iliac fossa pain, because if people have got right iliac fossa pain, they're diagnosed with acute appendicitis, they're operated. You may find the appendix normal, but in all cases, you should pull on the small bowel for a meter in order to exclude the Meckel. But this is out of the diagnosis. We're talking about a child who's got bleeding per rectum, and we're not very sure of the diagnosis. And then in adults, it's much easier, but in children, it's more complex. Then you can get, if you're suspecting a Meckel, you get a diverticulum scan. Only if it's bleeding, because it is this presentation that is related to the ectopic gastric mucosa. Okay?
Okay.
خلاص يبقى نتكلم بعد كده. We'll go on to discussing. قول مين اللي بيتكلم؟ قول يا عبد الله ازيك عامل ايه صباح الخير ازاي؟
بعد اذنك هو I don't understand how it has a tip and a base. مش المفروض هي هولو vagination من اليومين؟
مش سامع ايه؟
How it can has a base and a tip. مش هي المفروض هولو vagination يعني من اليومين ولا البيز دي continuing مع اليومين؟
لا the base is continuing with the human. Base
يعني
the point at which يعني the point at which it joins the bowel is its base.
تمام.
يعني the point that is most distal away from the bowel is its tip, but its opening into the bowel is its base. هي البيز دي هي اللي بتبقى المشكلة. You cannot just leave it, you cannot just invaginate it.
اوكي تمام.
حد جاب لنا الصورة ولا ممكن يعني ارسمها؟ هي كانت مرسومة في الأغلب في ورق مش في الورق ده، لكن we'll not wait, we'll get on to discussing the حازم. ممكن تمشينا كده على الميكونيوم إليس اللي وراها. أيوه بالظبط. Pradeep will go on now discussing. Pradeep, are you happy to continue?
Yes, doctor, really happy.
We're going to discuss Meconium ileus. دلوقتي we're going to discussing Meconium ileus. One other cause of neonatal intestinal obstruction. طبعا Meckel is a childhood problem, but Meconium ileus is usually a neonatal problem. احنا قلنا we're discussing 4 topics. This is our second. We hope to get this done very quickly, Pradeep.
Okay.
But at the same time, is someone looking for these images that I was asking for or not? If not, then it's not a problem. But yalla, Pradeep, tell me about, you know about Meconium ileus? What is, you know about ileus?
Meconium ileus and ileus, it's a paralysis because.
No, wait, ileus is not paralysis. Ileus is obstruction.
Sorry, obstruction. Anomalies.
Take care, ileus, because people propagate ileus as if it's an obstruction. They talk about someone having an ileus and they imply that this is paralytic, which is wrong. Because yes, if it were paralytic by default, you wouldn't have called it paralytic ileus. Yes. Paralytic ileus is a Goldstone ileus, it's Meconium ileus. Sometimes they say that ileus is colic, which is not correct. The best meaning of an ileus is an obstruction, not a colic. See, because it's a time said to be a painful obstruction, it is taken as if it's a colic, but it's not. An ileus is an obstruction. Goldstone ileus, Meconium ileus, paralytic ileus. You can talk about intestinal obstruction, you call it ileus instead of obstruction. Yalla.
And it obstructs the terminal ileum usually, and because that is the narrowest part.
Absolutely.
And what is this? Meckel's.
These are the diagrams of removing a Meckel. And you can see how with Meckel, you remove part of the bowel wall. You don't just remove the Meckel and invaginate it. You remove part of the bowel wall so that you're removing the base. Okay? This is okay. شكرا. Yalla, Pradeep, go on. We'll share this handout in a minute. Yes. It's the terminal that becomes obstructed.
And then that lead to the distension, passive backward distension of the bowel, and distal to the obstruction that with the long term that may get collapse, that lumen may get collapse, and I will follow this chart, doctor. After the distended bowel, that can lead to the.
What causes Meconium ileus? You did not tell me anything about what is the cause of Meconium ileus. What is happening with the Meconium in Meconium ileus? What is happening to the Meconium? And you've been talking about the fact that Meconium ileus obstructs the terminal bowel, the terminal ileum. That is correct because it's narrow. It's a narrow spot. Yeah, but what's happening? Why did it not happen in everyone?
Because there is some underlying disease that can lead to the Meconium formation. I mean, hardening of the stool, and
it's not the stools. We're not talking about the stools. We're talking about Meconium. We're not talking about the stools at the moment. We're talking about an earlier phase that is Meconium. Yes. What is the disease that is underlying? What is the underlying disease?
It's a cystic fibrosis.
So, okay, so this was the beginning. You should have been discussing the fact that this is one of the manifestations, the neonatal manifestations of cystic fibrosis. What was the former name of cystic fibrosis? What was its former name? Former
Mucoviscoidosis.
mucoviscoidosis. It's now called cystic fibrosis. Okay. What happens to the meconium in this situation? What happens to the meconium?
Meconium, and there will be very thick and hard because of less water absorption through the intestine.
It becomes really inspissated.
Insipid,
It doesn't
yes.
have a water content. It's inspissated, yes. And then it obstructs the terminal ileum, and it
Yes.
descends the bowel. Yes. And what happens when the ileum becomes very heavy with this meconium, heavy, inspissated, dried meconium?
That can lead to the volvulus formation.
Yeah, it can twist.
That can twist.
The heavy bowel twists.
Yes.
It twists, and twists can develop. Which age can twists develop?
Sorry, age? Doctor, you mean age?
I mean, what age? What age do twists develop?
Fetal.
They can be fetal, or they can be neonatal. Yes, but they can be fetal. And what happens if they're fetal? Okay, حصل fetal, what will happen when the ball twists? What happens to the twists?
Twisting can lead to the obstruction of the blood vessels, and that can lead to gangrene formation.
It can lead to what?
Gangrene for gangrenous. That can change into gangrene
in the newborn. But how about in fetal? How about intrauterine? What happens to the area?
In fetal, that cannot. Usually fetus, they drink the urine, and that cannot be absorbed. There will be polyhydramnios in fetal life.
Yeah, but what happens to the infarcted part? What happens to the infarcted part if it twists intrauterine? What happens to it? It does not become gangrenous because there are no bacteria. It just infarcts.
Yes.
What happens to it eventually?
Infarction, that is collapse. What
happens later on when an area infarcts, for example, in the heart, also down the brain? What happens to it?
That will later it will be reabsorbed.
And then what happens? What happens at the site of the wall that infarcted?
And there will be a missing part.
There will be a missing part. It will be replaced by fibrous band. That is, how do you call when there is no lumen of this part of the bowel? How do you call it?
It's no lumen means it's atretic.
Atretic. It's atresia. We've been talking about how the jejunum, the ileum twists inside the uterus, and they cause in the neonate jejunal and ileal atresia.
Yes.
اتفقنا على انه duodenal atresia is different from jejunal and ileal. I'm sure that you should be going through pediatrics. Pediatrics is a very small small module. It's a very small module, and you can master it like I don't know what. You can master it very easily. It's only a few topics. The method I go through things is that when things are really small, I tend to master them much more than anything else. I can sort of control them much more than the GI. I love the GI. Well, I think I present GIT problems in a beautiful way. طبعا I'm biased. Why do we start with these small modules? Because they're very limited and you can control them very easily. There are only 1 or 2 or 5 or I don't know 10 maybe topics, but they're very, very easy. But you have to make sure that you know them quite well, so that once we get to the more major modules, which is the general module, shock, hemorrhage, I don't know what, we can concentrate much more on these things. دلوقتي the duodenum becomes atretic because it fails to join the foregut, fails to join the midgut, and it's usually pre the ampulla. It's before the it's after the ampulla, so the vomiting is bilious. ده خلاص. أما the ileum and the jejunum, they're atretic because they twist intrauterine, and if they've got already heavy meconium, they are more and more prone to twist. So what happens when meconium gets to the outside? What happens when the meconium gets to the peritoneal, into the peritoneal cavity?
That can lead to the irritations of peritoneum, and that can lead to peritonitis.
Peritonitis, or زي ما بيقولوا meconium pseudocyst. It's very typical that once meconium gets to the outside, it becomes calcified. The intra-abdominal calcification in a neonate is pathognomonic of a meconium ileus. ما فيهاش يعني كلام. A ground glass appearance, obviously because the abdomen be full of the meconium, the ground glass appearance. The colon, you've been talking about how does the colon look like in meconium ileus?
Colon will be shrunken. I mean, it's small.
Yeah, but it's a microcolon. It's a microcolon بالظبط. If you want to treat a meconium ileus, how do you treat it? How do you treat a meconium ileus presenting in the neonatal period?
Initially, we first give drip and suck. I mean, it.
Suck, yes, yes.
And then with the help, we will give the contrast. What is it? Contrast enema, non-operative treatment.
Yeah, but how do you dissolve? How do you dissolve these this inspissated how do you call it, inspissated meconium? You dissolve it.
We will give some fluid enema to dissolve that.
So it's gastrographin. Gastrographin sort of absorbs water. It has hydrotropic. It absorbs water from the body into the lumen. And what dissolves the meconium?
Hypertonic solution. Hypertonic.
Yeah, but what dissolves it? There is some medication that we all know that dissolves viscid mucus everywhere in the body. And it's
N-acetylcysteine.
بالضبط. It's N-acetylcysteine. It's a magic drug. N-acetylcysteine. It's the mucolytic that we all know.
Yes.
And it's used to improve renal functions. And it is used also as an antidote for paracetamol. It's a very interesting medication. N-acetylcysteine. You can very well resort to non-operative management of these babies unless you suspect
any perforation or any complications.
بالضبط كده. If it's already dead or perforated, obviously will not. احنا اتفقنا انه whenever you encounter in some section any age group, the first point is you're talking about the presence of strangulation or bowel infarct or a perforation. Obviously, if these things are present or you simply suspect them, then there's no chance whatsoever that you give them conservative treatment. Otherwise, you're setting the scene for them to succumb. This is about meconium ileus. It's an ileus. Ileus يعني obstruction. Remember that ileus is obstruction. At times, it's mentioned that ileus is a colic. It's not the meconium plug. Meconium plug is something different. What do you know anything about the meconium plug?
Meconium plug. It's like obstructing the lumen. It's also hard insipid stool that obstruct the lumen.
I wouldn't like you to talk about stools. It's meconium. It's not typically stools. It's meconium. Where does it happen? Where does the meconium plug happen? Where is the site of obstruction in the meconium plug?
Usually in the rectum, anus.
It's not the small bowel. It's like Pradeep is telling us. It's on the left side of the colon. And is it associated with cystic fibrosis?
Yes.
A meconium plug is not. The meconium plug is a different etiology. It's totally different. A meconium plug is completely different. Meconium plug is inspissated meconium for any reason that is not something ongoing. It's just occludes the left side of the colon, and it usually becomes dislodged by conservative measure. That's it. It's very, very different. It's not the meconium plug. We're talking about the meconium ileus. That is causes neonatal obstruction in cystic fibrosis. Sometimes no cause is found. Rarely in older age groups. دايما you can expect things not to be very typical. Inspissated meconium obstructs the terminal ileum. It's because it's the narrowest. Distended bowel, also thickened. Heavy bowel, mid-gut volvulus. Gangrene or infarction, طبعا, depending upon the age, maybe fetal. It perforates. Meconium peritonitis, meconium pseudocyst. What's the difference between a peritonitis and a pseudocyst?
Peritonitis is generalized, I mean, inflammations, and pseudocyst is localized.
Pseudocyst is localized, yes. It's already being surrounded by fibrous tissue and the wall. But it's most famous as a pancreatic, but it can develop in any other situation. Abdominal calcification, atresia. If it's fetal and it twists and it perforates, it causes the intra-abdominal calcifications and it becomes atretic. But if it doesn't twist and it presents in the adult, it presents with a simple or a strangulated obstruction, whether it twists in, as not in the adult, in the neonatal. Okay, the ground glass appearance, when the abdomen is not clear and there is this appearance of ground glass. I'm sure you're well aware of ground glass through which you cannot see very clearly.
Long disease. I think, what was the disease? Long ground glass appearance also in long.
Well, it's COVID. It's COVID. It's the corona problem, but you can get ground glass appearances for so many other reasons. You can get the soot bubble, لأنه ممكن يبقى فيه soot bubble because of the thin effects of the meconium. The colon becomes smaller, obviously. Drip and suck, non-operative treatment using contrast enema, but you don't get barium because you don't want to perpetuate the problem. Give them something like gastrographin. Gastrographin has got the great advantage of absorbing water. It's hygroscopic. It absorbs water, imbibes water into the lumen, causing the meconium to become liquefied. And it's self-sustain. طبعا the famous mucolytic. At times, obviously, you'll have to operate if you cannot manage conservatively, or if it's already perforated or atretic. And then you remove the part. You may have to remove the part and perform a temporary ileostomy. Do you know anything about an annular pancreas? What is an annular pancreas here, Pradeep? Anything about annular pancreas?
Yes, during the growth, embryological period, when crias grow with it's on the duodenum from its lateral side of the duodenum, and it grows. How to explain in word? I just know that mechanism.
You've got mail.
How it grows. Usually in second part of duodenum it grows, and sometime.
What's an annular? What is an annular? What is meant by annular?
Annular meaning it's surrounding, it's covering.
You're talking about something and you're not hitting the problem. It surrounds the duodenum, and then what does it cause? If it's an annular pancreas instead of a pancreas that is only surrounded by the duodenum, it's the pancreas that surrounds the duodenum. And then what is it the cause of?
It will lead to intestinal obstruction.
Which part of the intestine will be obstructed?
It's the second part of duodenum.
طب خلاص, why don't you say that from the very beginning? It causes a second part of the duodenum obstruction, obstruction of the second part of the duodenum, because it surrounds it rather than being surrounded by it. خلاص, annular pancreas. What is the band of lead? What is the band of lead?
Bands of lead. It's
bands or band? The band of lead. The band of lead. What is the band of lead?
It's a malrotations usually present. Usually, which is bands of lead. Usually, it's a band of lead. It's a malrotation that lead to the shift from the right iliac fossa, right side, from the left side.
Let me just ask you, where does it extend from? Where does it extend from, this band of lead? It extends from which part of the abdomen to which other part?
From the right side. From the right side of cecum area, from the right side cecum area to the left side to Johnson.
Can we get the diagram? Hazem, can we get the diagram of non-rotation, please? الدياجرام ده رجعنا كده يا حازم، هتلاقي الدياجرام موجود. معلش يا حازم بتعبك. مش عارف فين هو الدياجرام that we've discussed a few days earlier. الدياجرام ما بيجيش موجود في ظهر. it was a separate drawing صح، بس ابعتها لك يا حازم.
تمام يا فندم. انا لو حضرتك تبعتها او انا ممكن اجيبها من النت لو حضرتك عايز.
لا 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 لا، انا هبعتها لك حالا، دلوقتي.
Doctor.
ايوه Pradeep, go on.
Actually, sometimes I really don't get what to describe that. Though I can see that image in my mind, but sometimes I really don't find word to explain it.
Work on it. You have to work on it. If you identify your problem, just work on it.
Okay.
What problems? What we do is at times we just submit to our problems, and this is really bad, but we have to work on it. It's not a problem. And I've got so many problems, but I tend to work on them. At times I'm fed up and they just don't give, I don't know what. And at other times I'm very enthusiastic. But it doesn't matter. But just work on it. Work on it. Work on it. فين هي بقى الصورة اللي أنا عاوزها دي؟ مش عارف ايه طالعة لي مش طالعة لي، تعدي مضايقاني اهي مشيت.
Okay, I will share it. This one.
ايوه هي دي. Is this, can you all now, are we all sharing this image of the band of lead? Can we all see the same diagram يا جماعة ولا are we all sharing it? Okay, this is the diagram. Go on. Where's the band of lead يا Pradeep? Where's the band of lead?
It is arising from the cecum. I mean, cecum and covering the duodenal part. Covering this.
Deep, just arising from the cecum. Where is it going? Where is it going?
It's going to the right upper quadrant.
To the right upper quadrant. What does it cross? What does it cross on its way to the right side?
It's crossing the duodenum.
It's the duodenum. So what does it obstruct?
It's obstruct the duodenum. I mean,
which part of the duodenum? Which part of the duodenum?
Second part of the duodenum.
Again, the second part. And it's associated with a cecum that lies on. Where did you say the cecum was?
On the left upper quadrant.
Left upper quadrant. That is. The cecum is, or the bowel is.
Sorry, doctor.
That is, the bowel is. What is the problem of the bowel if the cecum lies on the left hand side?
It's a problem, malrotation.
بس كده. يبقى you could have very easily mentioned that this individual has got a non-rotation or malrotation with the cecum located in the left side rather than the right, has got a band that crosses from the cecum that lies on the left side on this situation to the right upper quadrant, crossing the duodenum. Yes.
Okay.
And this is what we call the band of lead, and it's another cause of which part of the bowel does it obstruct?
It obstructs the second part of duodenum, and that causes the intestinal obstruction.
What did we just mention? Obstructing the second part of the duodenum. We just mentioned something. What did we just mention? Obstructing the second part of the duodenum.
Annular pancreas.
Annular pancreas. And that we mentioned a few minutes ago, Keda, and we've already discussed it in detail earlier. We've discussed something about the duodenum again, duodenal obstruction again in the neonate. What did you mention? What is the most common cause of duodenal obstruction in the neonate?
It's atresia, duodenal atresia.
Atresia, annular pancreas, band of lead are all causes of duodenal obstruction.
Yes.
Okay. طيب يبقى what is خلاص هنرجع بقى للورقة بتاعتنا تاني. I'm sorry about this disturbance, but we're progressing. We're getting to the end of our second part this morning because we've still got two other parts that we want to get over with. الورقة بتاعتي حزم اللي هي بتاعت الميكوفيزيدوزز والقصة دي معلش. الميكونيوم إليوس.
دي يا فندم؟
ورقة الميكونيوم إليوس هي دي انا مش عارف قدامي اصلي انا ورقة لسه حاططها انا كنت بعتها لك. Pradeep, okay, go on. What is henoch-Schullein purpura?
It's a blood disorder. It's it's autoimmune disease. In which blood vessels are medium-sized blood vessels are inflamed.
Okay, what am I just suffering a flight of ideas? Why am I mentioning it in this context?
Because
in the peds age group?
Because this is also one of the differential diagnoses for bleeding. And also the obstruction.
Bleeding from where? Bleeding from where?
Bleeding from anus.
Anal. You don't call it anal bleeding. You call it GIT, lower GIT bleeding.
Lower GIT, sorry.
You call it anal bleeding. It's not. You can call it hematochezia if you wish, but you don't call it. You don't call fresh being per rectum. You call it being per rectum. You don't call it anal bleeding. Okay. Henoch-Schullein purpura is like Pradeep was telling us. What is the synonym? Any synonyms for the disease? Henoch-Schullein is the eponym, but how do you describe it in other terms? Any other synonyms for the disease? Anaphylactoid purpura. It's autoimmune, and what manifestations other than purpura does it cause?
It causes abdominal pain.
Abdominal pain. It causes abdominal pain. Why does it cause abdominal pain?
It's I think vasculitis that can lead to infections, maybe.
Okay, that leads to what? Sorry, what leads to what?
Infections or.
Well, I mean, vasculitis doesn't usually lead to an infection. It causes a vasculitis in itself. It's painful, but at the same time, it causes bleeding inside the wall, and it causes obstruction. And if the wall bulges inside the lumen of the bowel, what does it cause?
Intussusception.
Intussusception. Henoch-Schullein purpura is a classic DD of an intussusception. It's a classic one. It's a classic. It's very rare in everything, but it's a classic differential diagnosis for intussusception. It's a classic differential diagnosis. It's a classic one.
Just now it's striking to my mind. I just remember the pedia notes.
Yeah, but I mean, you all have to read a bit more. You have to read so that we maximize and optimize the effects of these sessions. If you go on just reading them, just read them, just reading them like that, you'll just remember Henoch-Schullein purpura. It's a classic differential diagnosis of intussusception because it causes a bleed per rectum, and at times in itself it intussuscepts because of the bulge, because of the hematomas that bulge within the lumen. But it's a classic differential diagnosis. When a child, sorry, not a child, when an infant develops bleeding per rectum, it jumps to your mind that is, you want to exclude an intussusception in the first place. But it can be an enteritis, and it can be Henoch-Schullein purpura. And if it prolapses, through the anal verge, it can be a rectal prolapse versus an prolapsing intussusception. انتوا معايا يا جماعه ولا لا دلوقتي؟ انتوا قادرين تفولو؟ Are you following or are you not following? I want a clear answer. You're following what we're saying ولا احنا يعني زين بيقول ما اعرفش عاطف او عبد الله بيقولوا مي. Are you all generally following what we're saying? I hope. Just go and read the peds. It's a very small module. 10 صفحات. You can just read them, go through them. It's all about intestinal obstruction. مش عارف بقى vomiting وconstipation ودissension وcolics ومش عارف intussusception لاتريزيا لجيجنال لإيليا لديدينال Meconium ileus الهيرسبرانج، I don't know الانترسبشن، الحاجات كلها الميكونيوم إليوس. النهارده عملنا ايه تاني؟ ميكل طبعا not a cause of يعني not straightforward inside obstruction. Okay. يبقى the band of lead. I hope that you all know and you can have an image of the band of lead. You all know an annular pancreas and you all know something about the shoreline purpura. يبقى فاضل بس ناقص الحته بتاعت الجنرال بتاعت اللي هي الميكونيوم إليوس دي اللي هو الميكوفيزيدوزز. حازم ممكن تكبر لنا الحته، تجيب لنا الحته اللي جايه من فوق دي، او مش لازم نزوم عليها كده. ايوه اهو. Fibrosis is formerly يعني nowadays it's cystic fibrosis. It's autosomal recessive. It affects طبعا people succumb because of pulmonary problems, not anything else. Pancreatic, hepatic, intestinal, renal. It's the CFTR اللي هو the transmembrane regulator that causes the channel that causes control of sodium chloride, and it's excessive chloride in the sweat.
We get chloride test for this.
Okay, we will proceed now to the third part of our session this morning. Pradeep, are you continuing?
I think I will give opportunity to one of my colleague now.
Okay. Okay, Khalas. Thank you very much, Pradeep. And who will be the spokesperson? We'll be talking about a TOF and a congenital diaphragmatic hernia. هي في ورقة تانية يا حازم. On Thursday, we'll be doing the images, and on Wednesday we'll be doing how do you call it, a cleft lip in the palate. ايوه. يلا مين اللي هيبقى TOFs are well known. TOFs are well known. ومين اللي هيبقى ال spokesperson. We want to get these two items finished very quickly.
ايوه يا دكتور.
تمام يا دكتور، انا ممكن خلاص.
لا اطلع طب يا حازم.
لا خلاص.
اتفضل مش مشكلة.
تمام يا دكتور، انا ممكن اكون مع حضرتك.
يلا يا حازم يلا. What do you know about TOF?
Tracheo-esophageal fistula.
Yes. Okay.
بتكون associated with esophageal atresia. بتكون كذا type يعني.
It's standard type. Yes, there are so many types. But what is the standard type?
الموست common type بتكون انه البروكسيمال esophagus بيend as a blind pouch والlower part of the esophagus is يعني fistulate with the trachea.
What are the consequences? صح.
What are the consequences؟ انه النيونيتس بيكون عندهم reflux ده physiological عادي، فالريفلكس ده بيدخل على التراكيا بيعمل pneumonia.
What type of pneumonia؟ صح.
acidic pneumonitis.
بالظبط يبقى صح. And what happens also? What happens to the stomach? What gets inside the stomach?
What happens to the stomach؟ انه on X-ray بيكون بنلاقي فيها الجاز، فهنا we can differentiate انه بيبقى في اذا عايزين نديفرنشيت اذا فيها فيستولا ولا لا، لانه في تايبس ما بيكونش معاهم فيستولا.
هو is the fistula better or worse as regards the treatment?
It's worse of course، لانه هي بيبقى هنا زي ما قلت لحضرتك الاسيد ريفلكس.
بس as regards the treatment, as regards joining the esophagus, which is better?
joining the esophagus طبعا بيكون لما تكون في فيستولا احسن، لانه هيبقى الديستانس ما بين البلايند باوتش والفيستولا دي قصيره يعني، واللور بارت اوف esophagus قصيره، فنقدر نجوين.
Absolutely. يبقى osseous atresia obviously is an emergency. Like Hazem was telling us, the standard type is when the upper pouch ends blinding. and beware of diagnosis of a diverticulum in this age group. It's not a diverticulum, it's a atresia. Sometimes people mistake a diverticulum for atresia. Well, the lower pouch communicates with the airway. The air gets inside the stomach, and that is how you suspect the presence or you confirm the presence of a fistula by an X-ray. You just get an X-ray done and you encounter air inside the stomach. On the other hand, the acid of the stomach gets inside the lungs and it causes an acid pneumonitis, like Hazem was telling us. Now, what are the consequences of the upper blind pouch?
الابر بلان باوتش لما اليونيت ده يجي يرضع من مامته فهي برضو الميلك ده هي ريجيرج يدخل في الاير واي.
يعني هيحصل له ايه؟ الكلمه اسمها ايه؟ بيقولوا عليه بايه؟
هي اسبيريت.
هي اسبيريت. لازم لما only when he's nursed ولا before he's nursed؟
لا before even his nurse حتى بيبقى عنده saliva frothy saliva.
تمام، يبقى he's dribbling his saliva, the saliva is frothy, he aspirates his saliva, he's drowning in those secretions like we say. He chokes and he suffers each and every time he's fed. Okay.
هو بيكون سيانوتيك يا دكتور كمان، يعني ممكن يكون سيانوتيك؟
يا طبعا اكيد. What are the other types?
في اعتقد السكند موست كومن تايب انه ما بيبقاش فيهم فيستولا، يعني في upper blind pouch والlower end of esophagus من غير فيستولا مع التراكيه.
تمام. What about the other types?
بعد كده ممكن يبقى upper part of esophagus هو اللي fistulate with the trachea، وممكن يبقى both ends fistulate with the trachea.
lower part, what about the
lower part بيكون blind اعتقد، يعني ما blind.
معاك يا حازم، معلش متاسف.
تمام يا فندم.
طيب يلا ايه. what other configurations can we have؟
هو احنا كنا بنقول التايبس، احنا كنا وصلنا انه بيبقى في ثالث نوع ان هو ممكن يبقى في فيستولا بين الابر بارت والتراكيه، بس اللور بارت بيبقى بلايند.
تمام. how about the other configurations يعني types. It's the same thing. What other types can we have?
We can have both ends of the esophagus may fistulate, the upper end and the lower end of the esophagus fistulate with the trachea.
ايوه يا ايه بيفستريت يا ايه هاو. انا رسم واحده لكن في واحده ثانيه ممكن تبقى ايه؟
ممكن تبقى اللي هي اتش شيبد، بيبقى continuous الاسوفيجاس continuous وستيل بينه وبين بين التراكيه في زي كونكشن.
تمام. يبقى حازم has beautifully demonstrated the different types of arterial atresia. طبعا atresia with a fistula او arterial fistula, the better name, because in the vast majority there is a fistula, as you can see. In 87% or more or less, the fistula is with the lower part and the upper part is ending blindly. It's a disease of boys and it's one in 4,000. Hazem L, the frothy saliva, the cyanotic episodes, the first in all feeds, the rigors, the abdominal distension. Why is the abdomen distended?
عشان البيبي when he breathes هي الجاز ده بيدخل على لأن في فيستولا
بالظبط.
والتراكيه.
بالظبط. We're talking about the fact that people get the air, or these babies get their air inside their stomachs and their abdomen becomes distended. They've got frothy saliva. They choke and they suffer cyanosis during their first and all feeds. Obviously they regurg. ده على طول بيبقى diagnosis واضح. How do you confirm the diagnosis؟
بالكاثيتر او نيزو جاستريك تيوب، بس يكون ثيك تيوب.
مالها؟
يعني نيزو جاستريك تيوب بندخلها هنلاقيها ونصوره اكس راي هنلاقي التيوب بيكويل في اللور في البلايند باوتش ده.
تمام. why do you get a plain film? Why would you get a plain film?
عشان لو حطينا اي صبغه هيسبيريت.
يبقى we don't recommend the old contrast studies because of the possibility of aspiration. But why do you get a plain film? يعني why do you still get a plain film?
عشان اعرف اولا انه التايب او الكونفيجريشن زي ما قلت لحضرتك. لو عندنا جاز اير بابل يبقى احنا هنا كده عندنا كونكشن باللور اند والتراكيه، وبعدين عشان اشوف الكويلنج.
تمام. يبقى you want to see whether there is air inside the stomach. What do you see about the lungs? What do you want to see about the lungs also?
اللنجز ممكن الاقي عليها الساين بقى اوف نيمونيا وانفكشن.
تمام. طبعا you get blood gases، حاجه يعني مش عاوزه. One of the complications are an aspiration, an acid pneumonia, dehydration, hypoglycemia. طيب و you can diagnose them at an earlier phase obviously.
اكيد لو يعني دكتور النساء المفروض نشوف ان الام عندها polyhydramnios.
بالظبط. polyhydramnios. You can find a polyhydramnios obviously because it's not swallowed, just like people with intestinal obstruction. obviously you can diagnose it using ultrasound prenatal. طب يلا هنعمل لهم ايه الاطفال دول؟ This is an emergency. Remember that if you're in outpatients or you're in casualty and you encounter this neonate with this sort of thing, dribbling of saliva, frothy saliva, these episodes of choking and cyanosis whenever they're fed, they've got the tough until otherwise. It's not a big issue يعني. يلا how would you treat them?
اول حاجه nothing per oral ونحط نيزو جاستريك تيوب عشان نعمل سكشن للسلايفا عشان ما يحصلهاش اسبيريشن.
تمام.
وبعدين نحاول نتريت النيمونيا، وفي نفس الوقت ان نصلح له اي اسيد بيس بالانس والديهايدريشن والهايبوجلايسيميا يعني والالكترولايت امبالانس، نصلح له الكلام ده بارنترال يعني.
وبعدين
بقى نوبريت.
الاوبريت هنعمل ايه يعني؟
لازم اول حاجه يعني نقفل الفيستولا دي، نلايجيت الفيستولا او ندسكت الفيستولا بين اللور اسوفيجاس والتراكيه.
ايوه. ونعمل ايه كمان؟
نحاول بقى نوصل التو اندز.
تمام. Is arterial anastomosis a safe undertaking? Is it something safe to perform arterial anastomosis? عاوزين نشوف ايه اللي مكتوب تحت كده يا حازم، من فضلك طلع لنا الكلام ده عشان نبقى خلصنا، وهنشوف بقى بعد كده السي دي اتش. يبقى stop oral feeding, aspirate the saliva, feed the pneumonia, operate urgently. وزي ما حازم قال بقى you separate and you anastomose. وطبعا you all know that the proximal foregut normally divides into an airway and esophagus. ساعات يقولها air digestive كلام حتى على التروما اوكي يقولوا air digestive على بعض. يبقى we've come to the end of our third يعني item in our menu this morning. وناقصنا بقى لاخر حاجه. يلا يا حازم بقى اخر حته اللي هي congenital diaphragmatic hernia.
تمام. congenital diaphragmatic hernia هي تو تايبس اعتقد، مورجاجني مورجاجني لما يكون انه السيبتوم مش كونكتد بالسترنو كوستال هيد.
يعني بتبقى anterior ولا posterior؟
دي انتيرو. لا سترنو كوستال هيد بيبقى انتيرو.
Is this common ولا uncommon؟
uncommon. البوستيريور هي المور كومن لما يكون في persistent باللورو.
Why don't you start with the common thing? The common thing is posterior. How do you call the opening?
بوكداليك.
The bogdalic بالظبط, and it presents as herniation to the posterior mediastinum. And what is the problem of the congenital diaphragmatic hernia? تيجي left ولا right؟ ليه بتيجي right؟
more common left عشان الرايت فيه الليفر.
تمام. And because the fusion is earlier. Yes. And what happens? What is the major problem of a congenital diaphragmatic hernia?
يعني بيبقى فيه بريشر على اللنج بيعمل لها ابليجيا.
يبقى absolutely. يبقى this is the problem. And when the lung is hypoplastic, what happens?
هو هيكون عنده يعني البيبي بيتولد بيبقى manifestation of respiratory distress syndrome.
يعني ايه يعني what do you mean by that?
يعني البيشنت is tachypnic عنده respiratory distress cyanotic ف
تمام
hypooxygenated بقى كده.
معاك يا حازم.
تمام يا دكتور.
انت بس ما قلتليش the lungs are hypoplastic because they cannot develop because of the bowel loops, and when the lungs collapse what happens?
بيبقى عنده manifestation of respiratory distress بيبقى البيبي بيبقى cyanotic.
What happens? Something very important happens. What happens when the lung is hypoplastic?
pulmonary hypertension.
أيوة بيجي لهم pulmonary hypertension.
بالظبط.
It's the main problem here. The problem with the congenital diaphragmatic hernia is the pulmonary hypertension that these infants have, and it's not about just reducing the hernia and that's it يعني.
بالظبط.
الهرنيا زي اللي قلنا تاني بيجوا على الناحية اليمين are they left sided or right sided؟
more commonly بيبقوا left sided. ممكن يجوا في اي حته بس هم left sided more commonly يعني.
وبيبقوا anterior or posterior؟
posterior more common برضه than anterior.
يبقى الليفت اهو 5 compared to 1 posterior 90% بوجداليك anterior morgagni lung hypoplasia obviously pulmonary hypertension contractile compression respiratory distress. Why is the abdomen scaphoid؟
لانه اللوبس الباول لوبس كلها فوق خلاص بقى في الجست فالابدومن ما فيهوش حاجه.
تمام. What can happen to the bowel loops that have already herniated like any herniated bowel loops? What can happen to them?
risk of strangulation مثلا.
تمام بالظبط كده risk of obstruction and strangulation, but the main problem of these infants is a pulmonary one obviously, not because of the compression but much more because of the pulmonary hypertension. Even if you reduce the thing you need to manage the pulmonary hypertension. What is ECMO? What is ECMO?
اكمو لا مش عارف دكتور مش عارف.
لا انت عارفه اكيد. انت عارف الاكمو. I'm sure you know ECMO is extracorporeal membrane oxygenator. If someone has got CDH or if the lungs are unable to manage with a ventilator, then you put them on an ECMO. That is, you get their blood to the extracorporeal circulation, you ionize them, you oxygenate them through a membrane, and you get them back to you get the oxygenated blood back to the circulation.
ده في البلمونري هايبرتنشن قصد حضرتك؟
When people are not managing properly with the ventilator, you put them on ECMO. ففي الاكمو اللي هو extracorporeal shock قصدي extracorporeal membrane oxygenator. الاكمو او الاكستراكوربوريال carbon dioxide remover. لكن الاكمو ده مشهور قوي when people have got a respiratory problem and they've got basically a diffusion problem and you cannot overcome it with increasing the concentration of oxygen in the inspired oxygen or on a ventilator. Then you cannulate their femoral artery and vein, you get their blood to the outside, you hyperonize them. It's like an extracorporeal circulation, and you pass their blood through a circuit to the membrane that oxygenates the blood, and you get the oxygenated blood back to the circulation. It's just like dialysis, but dialysis obviously dialyze, not provide them with oxygen. Just like an extracorporeal circulation in cardiopulmonary in open heart surgery زي ما زين بيقول بالظبط. يبقى I think that we've discussed everything about that. طبعا زي ما زي ما كان حازم بيقول the costal and sternal parts, the costal, the ribs develop, the diaphragm develops from the sternum, from the costal, if you remember the crura, and obviously the ribs, and it develops also from the septum transversarium. The septum transversarium pleuroperitoneal folds, if they don't fuse, right before the left, that is why it's common on the left. It's not only because of the liver, but because the right fuses before the left. If the septum transversarium that is in the middle, and the pleuroperitoneal folds obviously that come from the sides, and they have to fuse together. If they don't fuse, then the result is a right-sided posterior common Bogdalic hernia. While if the costal and sternal parts not fuse, the costal, the ribs, and the sternal, يبقى دي بتاعت المورجاجني. That's the problem of these babies is not reducing the hernia at all. This is not the emergency. The problem is improving their lung functions. يبقى we'll stop at this point this morning. ومتشكر يا حازم، متشكر يا براديب.
شكرا يا دكتور.
ومتشكر يا حازم for hosting. ومحمد يبقى كويس. شكرا يا براديب. I hope to see you tomorrow إن شاء الله. لا not tomorrow بقى. I'll see you إن شاء الله on Wednesday. Wednesday. هنبقى we hope to go through the clip and palate and anal malformations. We've got two topics. So if someone is preparing for being the spokesperson, I would very, very much recommend that you read these two topics so that we go through them very swiftly, inshallah. Okay?
تمام يا دكتور.
شكرا يا حازم، متشكر قوي.